My name's Hasan. I'm from the UK. I've been diagnosed with keratoconus about 10 years ago. I came here 3 months ago and I had Intacs fitted in my left eye, and I'm now back here 3 months on and I've had laser plastic done on my right eye, and today is day 1 after the surgery.
Sure.
And the reason why we're having this meeting and we're having this conversation is because I sat around the table with a group of your patients, and I listened to their stories, and it made me sad, to be honest, listening to them and seeing the torture and the suffering that they went through. And just to put things in the context, I'm a camera shy person. I'm not really one to talk publicly, but the reason why I feel the need to do it is because of some of the patients I spoke to, in particular Jonathan.
Yeah. Correct.
So I got to ask these questions, and I know when 10 years ago when I was diagnosed with keratoconus, I was lost. I didn't know which direction to go to. So I thought it'd be nice if we asked the questions to Dr. Gulani and see what he says.
Anytime. Well, these videos you have actually, all of you have seen before you all come to me too, right? And now you're a part of this. So guys, it's 5 o'clock, busy Friday we've had, seeing all our post-ups, and we're at the end of our day actually, and Hasan is part of the patients who's day 1 post-up after laserplasty, among patients who came here from all over the planet. He's from London and he's heading back tomorrow. And when he said to me right now, can we, because he saw all these patients himself, which for us it's every day, he said, can you answer a few questions for the benefit of others? And I said, absolutely. So this is, again, as usual, impromptu. It's the fag end of the day, but none of us are tired. It's just very exhilarating for me for what I get to do. So shoot your questions up, go.
So the first thing that I wanted to ask was, if you've just been diagnosed with keratoconus, what's the first thing that you should do? Because the first thing I did when I was first diagnosed, I went to see a specialist. The specialist, first thing that they recommended was crosslinking. If you do a quick Google or you go on YouTube, the first thing everyone suggests is crosslink. Now, is that the way to go, or is it?
So they're not wrong. Crosslinking is approved for preventing the progress of keratoconus, right? Here's where I differ on that concept. If you think of crosslinking, and I call this the this has come to know now as the Gulani keratoscoliosis concept, is crosslinking. Think of your keratoconus as a spine that is irregular, right? Your cornea is like a cone. Now with this irregular and D-shaped, and think of your back as kyphosis, we call it, right? Like a bent spine. Now, instead of fixing that spine first, you're just putting cement on it and telling people it won't bend anymore. Correct, but you left that patient disabled for life in that position. Now, caveat. I still believe crosslinking should be done for patients whose vision and refraction keeps on changing. These are mostly people in their younger ages, right? To stabilize them. Also in certain patients, even though age crosslinks people naturally, in certain people it's still been proven, even up to 50, 60 years, they still keep changing. Whenever you see that change is happening, crosslink the patient. But once there is stability and no movement, go for vision. The biggest problem with keratoconus is that doctors too, my colleagues, while I teach them also, the very word keratoconus confuses and scares people. In fact, it scares even the doctor who's making the diagnosis, and then when everybody's scared, the options decrease and the goals completely vanish. It just becomes a scenario of, I'm sorry you have keratoconus and there's nothing much we can do, and live with it. That's not an answer. How I look at keratoconus, I in fact define it to break it down. I call it, take every giant, break it into a snicker-eating, boxer shorts wearing dwarf, and then go after it. So keratoconus to me is nothing more than a relatively abnormal cornea, which is relatively thinner than normal, with high keratometry, usually astigmatism, sometimes myopia, sometimes hyperopia, and may or may not have a scar. When you look at keratoconus like that, you suddenly get away all the fear of the word keratoconus. So when you break it down, it's basically a relatively thin cornea with abnormality. Now, so crosslinking. Once you're first diagnosed with keratoconus, as I do with all of you, I look for vision potential. You've seen me struggling with you all with the street retinoscope, even with millions of dollars worth of technologies you've been through in my institute. I come here and I start refracting, looking for what I call my gold vision. Once you have vision potential, the doctor should work on the vision direction, not just leave you, crosslink and leave you. Contact lenses are important, very important, but that's an addendum to your correction, to take it from the correction to better correction, if you may. You cannot just put a contact lens on and let the patient deteriorate underneath over years, because the patient will wear it to see better because it's a huge incentive, but there's no treatment. You didn't treat it. The weakened bone keeps on weakening and bending over time. Anyways, then the patients come in a scenario where they're so thin by the time they come to me, you have very little options remaining. So cross-linking is great technology, it's FDA approved, very, very important. I've been involved in it for over 2 decades, but there's a time to do it. And I will describe the keratoscoliosis concept so people understand that. So if you go here, so this is important for your questions. So if you look at your eyeball, just think about a spine, okay? Our spine. So if our spine is bent like this, that's an abnormality. Now, we first should fix this spine, make it straight, and then you can cross-link it. Let's call this cement, okay? But if you cross-link it while it's bent, of course claiming that it won't bend anymore, but you still have it bent for life. So that's the concept, keratoscoliosis. So be careful, ask for options. Hey doc, after you do this, what happens to my vision? But that's your ask. Your ask is not about, doctor, what do I do with my cornea? You're a patient. Your desire is vision. Does that answer your question?
Yes. The only thing that I would say is that from my experience, the patients don't know that there are options.
Yes.
So the first assumption is your only option is cross-linking, get that done, stabilize it. But actually, you may not be progressing, you might be stable, therefore correct it and then cross-link.
Correct.
That's it. One of the biggest issues is that people don't know that there are options.
So, for example, as we, while you were talking, we even pulled out these recent patients we've done. Here's, for example, a patient where I did it my way. Here's a gentleman, he's actually a firefighter. Came to me with this keratoconus. I laser plastic on him. Laser plastics, which you had yesterday. How painful was it?
No pain.
Minutes. Brought him to 2020. If you see the astigmatism is 0. See that?
0.
0. So brought him to 0 and then cross-linked him. He's a firefighter. In fact, he just sent me a picture of him saving someone's house on fire. It's amazing what it can do to people, and it's safe. Right? Does that answer your question?
Yes, it does, yeah.
Next.
So, I've had cross-linking 10 years ago. In hindsight, I would have measured it to see if it was progressing, and I would have then corrected it and then cross-linked. Recently, in November, I went to see a specialist, a professor, and I did a pentacam scan, and he compared my pentacam, my new one, with my old one, and the conclusion was that my thickness on my left cornea was about 200 microns and my right cornea was about 400, which is just about the threshold for cross-linking again. So his decision was simple: wait potentially for corneal transplant on my left eye, because there's nothing else you can do, it's too thin. Right eye, monitor it, see if it progresses. If it does, cross-link again. Those were my options. Now, my question to you is simple, because I've been watching YouTube trying to work out whether the thickness of the cornea matters.
Yes.
That doesn't matter.
Yes, it does, but see how my logic works. Let's take you, for example, what you just said. Your doctor, a very able doctor, I'm sure, in London, said for your left eye, because it was 200 microns, they said nothing can be done, wait till you go blind enough and have a transplant. To me, that's not an answer. In your right eye, they said 400 microns, let's get recross-linked, but without correcting your
Vision.
No. So what did we do? When you came to me with that problem, I first, in your left eye, did an intact. In your 200 micron cornea, it's just about how hard you want to work as a doctor. So we put this even in this very thin cornea, and how's your vision?
Fine. It's improved.
Right?
Yeah.
Improved. And we even measured you down to 20/40 in this eye. You had come with count fingers.
Yeah.
So doctors, that is completely incorrect. You have 200 microns, wait for a transplant. This young man has kids when he came last time, right? You have to think about the human being here. You can't just say, wait till you're blind enough and then let's put a transplant, which doesn't give you vision anyways. You need a contact after that. So we did this in him. It was difficult, but how long did the surgery take? Was it painful? You went to Disney, I remember, after that.
Yeah.
Totally don't go. But there you was. So here he is. Now, he came to me 3 months later, which is this week, and right eye, because he has vision potential, what did I do? Laser plastic. Can you even tell he had surgery? There's no evidence of surgery. There's no cuts, no flaps. Now coming to thickness. First of all, here we corrected 6.8 diopters astigmatism in you. Yesterday. Today is day 1. Any pain?
No pain.
How does he look doctors. I mean, any pain, any evidence that he's actually come here. It's like I said, 5 o'clock. I should be very tired, but I'm exhilarated with the work, and he's grilling me, and I love this. If it's for patients, more power to you. So we did laserplasty on his eye. Are you already seeing a difference, son?
Yes. Well, normally I wear glasses.
There you go. So by telling this young man nothing could be done, was not an option. Now where does thickness come in? So very, very big misnomer. You see, I explained it this way. Somebody who's 5 feet tall is either relatively tall or short compared to what you're comparing him to. It is not an abnormal height. But someone 4 feet tall or 11 feet tall is surely a pathology of some kind. So a number doesn't decide whether you're abnormal. It just decides you're relatively thinner, which you expect in K-corners. Laser plastique I prefer in patients who are around or over 400 microns, over 30 years of age. So they're more or less stable. There's proof of stability, and I can refract them myself to vision endpoint, which you perceive. Remember, I make you perceive 1 to 10, you say 10 on 10. And when astigmatism is more than myopia. Because by the laser algorithm, if you understand lasers, it removes the least amount of tissue in astigmatism. So when you remove hardly 20 to 30 microns, and you bring these patients to 20/20 vision, that's amazing. Safety, your epithelium itself is 60 microns. How do you compare that to a damage to keratoconus? No, you're not cutting, you're not doing LASIK, this is laser plastique. You're shaping the cornea with the laser in the most atraumatic fashion. Any pain at all? No. And no, this is not PRK, otherwise he'd be in pain, he'd be having haze, regression. Have you seen any of that? No special medications at all. So that's laser plastique. That's how corneal thickness comes in. So thickness doesn't mean abnormal. It's relatively different. As long as you don't find abnormality, there's stability, you can laser plastique on it and make these patients see. Does that make sense? In fact, you're a perfect example of that discussion. Not to give up. Next question.
So my next question is about techniques and technologies of which surgery to use. Now,
Sure.
I was sitting around the table and I was talking to your patients, and everyone was talking about their experience and some of the things that went wrong for them. Now clearly they went to see another doctor, and that doctor suggested doing this technique or this surgery, and that's obviously been the wrong decision. How do you decide which technology, which technique to use, and why aren't everyone else following that sort of structure?
So I'm sure they're all capable doctors, but I call that GPS. You have to plan it in the correct direction, right? You can't just do this, and then if this doesn't work, do this. If that doesn't work, do that. Now the patient has spent money, we've done multiple surgeries, and the patient's gone from one dead end to a side turn to a complete stand-stop there. So very important to logically plan ahead, right? In your case, remember when I did that special intact technique, I told you may need a transplant. So you could still need a transplant, but the fact that we got you to vision, it's the logical direction. Now, if you see these patients, you saw all of them today. For example, when do I do ICL in these cases? ICL is done when the keratoconus is stable, measurable, and the myopia is more than astigmatism, nearsightedness is more than astigmatism. So here are these patients, they see perfect, the ICL is in place, nobody sees it, nobody feels it, they're done. Intacts I do when the patient has no visual potential, meaning they've crossed from visual to structural situation. And there you can have so many kinds of permutations I do of 1 ring, 2 rings, and positions. For example, this is an army officer. Where is you? I did your, if you see yours here, here you are. You see this kind of concept here? Single ring on the side to lift up a very high astigmatism. And these are all things you can do. Here's a patient with LASIK ectasia, which is a LASIK complication like keratoconus. Here she is 20/20 with the ring placed right along the high astigmatism axis. And then you saw the patient from Paris with you here. He had how many rings? 3 rings, 2 laser techniques, 2 corneal techniques, and blinded. This is how he came here. Today morning you had seen, here you go. So you can see this image here. These are Kera rings, this is intact, he had PTK, cross-linking, all the stuff done. Now all these doctors were well-meaning, but the logic and GPS is missing here. So finally ends with total unmeasurable cornea. And what was the vision? Hand motion when he came.
So what did you do to that patient?
So here, because he's no longer visual, he's structural, I decided I have to remove these guys. Because if I do laser plastic on a damaged foundation, I'm not aiming for success. So I had to remove all these meticulously, and you saw him, I did a layered corneoplastic level for him, like this. And this is how they look. And he could already see his mother today. You saw him, he was sitting and chatting with you, and he's ready to fly out. So this is the concept. All these are levels of surgeries you can do. As I said, even these patients who come with keratoconus, but cataract age group, over 60, right? They have cataract. You can use premium lens technology and see the astigmatism here. Zero. Important. So all of these patients can be fixed. Now, to answer your question more deeply, as you know me, when someone asks a question, I love to explain, is if we go now and look at how I think, just like with you. You're my patient. You all know how we do things here. So this is your eyeball. Keratoconus is like this. Let's exaggerate it. That's the cornea. So the problem here is it's high keratometry, meaning steep, it's thin. It has mostly astigmatism, sometimes nearsightedness, farsightedness, and may have a scar. So when you present to me like this, the first thing I go for is refraction. How do you see? If you see well enough, it means you are visual. So doctors, among 28 techniques that I do, I break it down into two simple categories: visual and structural. If you just remember this, for patients and doctors, this is so easy now. The fact that the patient can see puts them in this category. The fact that they cannot see well puts them in this category. Structural meaning you have to build up something. Visual meaning it'll go straight to vision, 20/20 or whatever it is. So when someone comes with keratoconus to me and I find that they are visual, I can do laser plastic surgery, a non-cutting laser technique, shape the cornea into a perfect basketball, and they are 20/20. We removed how much tissue here? Most likely 30 microns, 40 microns max. Laser plastic. Let's say they have a scar with the keratoconus. I peel the scar off and do my laser plastic at the same time. Like the guy you saw from Atlanta. Same today, right? The guy with severe scarring, he has cross-linking failures and stuff before. That's why. Now, let's say you have very high nearsightedness with astigmatism, but nearsighted is extremely high and you have keratoconus. As long as this is still visual, I go inside the eye and put in an ICL. ICL is like a contact lens you can put inside the eye on your natural lens, and you are done forever, right? Inside the eye. So you're taking care of refractive error without touching the cornea. There are cases I've done combination. You saw the other guy today. I put an ICL and then I do laser plastic on the cornea to correct residual astigmatism. As long as they are visual, we make it less crowded here. As long as they are visual, it is the doctor's responsibility to maintain vision and get there, not to do structural surgeries and take away vision. That's the point. Now, you come here and your cornea is, let's say, 200 microns, very thin, has scars, you're no longer visual. No matter what refraction we do, you just can't see well. Everything is double, distorted, everything. Now, as long as you're not cross-linked, I still have a nice predictability here. I can put in intact rings into the cornea, put a ring in the cornea that shapes the cornea and brings you to vision. And I can still, on top of that, do laser plastic and bring them to excellent vision. Many of these are 20/20. Now, if you have scar with this, I can still peel away the scar and put the intacts in. And what intact does is, as you saw on the topography, brings your shape to perfection. Correct? But these are still a structural level. So they may not directly go to 20/20. They will still need, here's where the contact lens comes in, scleral contacts, specialty contacts, whatever. Now, let's say they are scarred and very thin, like 100 microns, or have a total mess like this gentleman we had with rings all over. Now what I did is, I will now take this top layer off the cornea. Think of the cornea as 6 slices. I'm taking away the top 2 layers, which contain the rings and everything, with my hand dissection, with diamonds and instruments that I've designed, and then just replace that top layer with donor tissue of 3-layer thickness. So not only have I removed the scar, I have also decreased the keratometry, meaning I have flattened them. At the same time, I have added thickness. By doing this, I have reversed his complete genetics. Because by doing this now, I have a normal cornea on which I can come back and play with the laser, do laser plastic and bring them straight to vision. Are you with me?
Yeah.
So we took structural, created the foundation, and then with laser went refractive, visual, straight to vision. Or let's say after this structural correction, he is very high myopic. What will I do?
Toric ICL.
Lovely. Put an ICL inside. Absolutely correct. So you see how this concept goes, and there's no limits to combinations. Worst comes to worst, you see me do a lamellar technique there, combination techniques, but not needed. Now if it's an adult with keratoconus, and by this age they have cataract, right? Cloudy lens. No big deal. As long as this is stable and visually correctable. I go inside the eye, we remove the cataract, put in a high definition lens which has astigmatism correction and correction of myopia or myopia, whatever, straight to vision. Leave the keratoconic cornea there. Because by age, most people get cross-linked naturally. Now, where does cross-link come in? Once I have done laser plastique on these corneas and brought them to perfect shape in 2020, now I'm okay if these patients are, let's say, if they're less than 30 years of age or something, cross-link them. And that to cross-link in a way which doesn't hurt, without breaking the epithelium. And that's it, they are permanized. Done. Does that answer your question?
Yes.
So there is no limit, doctors and patients, for what you can do. Keratoconus to me doesn't mean that you have a death sentence or blindness sentence here. It has to be looked at, and like I said, take all my 28 techniques, break them into just 2 categories. Can you still see, or have you stopped seeing and it's structural? This decides what direction I take with y'all. Once I decide that, there is no limit to the number of technologies and techniques I use, because my goal then is vision. I need vision. That's where we take you. Now, if you come to me cross-linked, come to me with previous procedures, it makes my work more difficult because now I'm working against the cement that you have on your cornea, right? Like we discussed with y'all. That's where my predictability goes down. Not only can I not predict 2020, I cannot predict how you will do, even though I know you will do well. So then that's when I have to wait and watch y'all over 3 months. Then you go into a specialty context or something with your doctors back home, and then you're done. Does that help?
Yes, definitely.
Yes? So guys, really, if you have keratoconus, nothing to worry. Again, I appreciate my patients, even though it's late in the day today. But my own patients asking me questions, I never say no. It's a pleasure to share with you all. And so keep educating yourself. Don't fall for gimmicks. Interrogate, investigate, and ask questions, because you can be helped. So, Hasan, anything else? Was that helpful?
Yes, that explains everything. Visual, structural.
Yes.
Very clear.
Very simple.
Yeah.
No confusion about I saw this topography, I saw this scan. All I ask you, if you remember when you all called me first time, what do I ask you? What's your vision?
Yeah.
Are you correctable? That's how my brain moves. If the vision part is there, it is the doctor's responsibility to take you to vision. Once you lost the vision potential and you're all confused, glasses don't work, contact, now you become structural. Now, whether you have a scar or how thin you are, doesn't matter to me, it's structural. That's when again I go least interventional, whether it's intact, lamellar, whatever. Penetrating transplant or corneal transplant should be your last resort. It's not wrong, it's right by the textbook. To me, logically, it should be the last resort, because most of these are young patients with their lives and families and sports in place. You cannot deprive their life by doing something easy to you. You want to take care of them, think of them, give them vision. Yes, keratoconus is difficult. Even the measurement, how many times do I see y'all before surgery?
Many times.
How many times do I measure y'all myself?
Many times.
And I'm not exhausted. I've just finished 19 patients and they are all flying out. Many of them flew out already. You're waiting to go back to London. But it gives me so much pleasure to see them like this, and genuine people. And then when they get interested, I mean, this is every Friday for us here, right? When you come, you're the only patient. Remember, 1 patient at a time enters. My pride, we don't have a waiting room, it's a lobby. But when you're leaving on Friday, there are 25, 30 people, and today you saw them chatting with each other, doctors, lawyers from every part of the world, and each one has the same request. They want to see.
Yeah.
So for patients, please do your research, do not fall for gimmicks. For doctors, don't give up on any patient. It can be corrected, no big deal. Just fight for them at least. They know it's not normal. They know this is not LASIK and a quick fix or a guarantee, but they deserve help. You can't just let them fall and become what I call dependent and disabled. Cannot. Got to rise them, pick them up, fight, and it's possible. We have fixed practically every concept of keratoconus here. As when you mentioned, I just pulled up even from the desktop this week's patient, and it's so many cases. In fact, tomorrow I'm doing a worldwide webinar on this keratoconus. I call it Think Outside the Cone. All thanks to my patients who allowed me the confidence to perform. Right, so safe travels back. Give our love to the kids. Take care.
Thank you so much.